abstract 1709 describes a verified study, a phase 3 study of the hepcidin mimetic rusfertide, also known as PTG 300, in patients with polycythemia vera. Now, polycythemia vera is the disease or neoplasm of the bone marrow where everything grows, red blood cells, white cells, and platelets. But the number one problem universally present is uncontrolled growth of red blood cells. Increased number of red blood cells in circulation leads to thrombosis. And typically, when we see patients with newly diagnosed polycythemia vera, we would address the issue of a thrombotic risk. And we would institute measures to decrease it. And the number one measure is phlebotomy, a bloodletting that would effectively decrease the red blood cell count. In some patients, which we call high risk for thrombosis, we would also add a cytoreductive therapy like hydroxyurea or interferon or ruxolitinib, approved therapies to control the proliferation to extent possible. But everybody gets phlebotomy and also baby aspirin to decrease the stickiness between the cells. Now, it transpired that many patients, whether they are low risk for thrombosis or high risk for thrombosis, require many phlebotomies. That is not really valuable for them. The goal would be to eliminate need for phlebotomy as much as possible, decrease it or eliminate it completely, particularly in patients with a high risk for blood clot. That means hematocrit below 45%. In phase 2 open label study, this particular drug, rusfertide, which is hepcidin mimetic and therefore redistributes the iron within the body, keeping it in the reticuloendothelial system inside the liver, spleen, and the lining of the GI tract and preventing it from entering the bone marrow, you see in the phase 2 study results significant, in great majority of the patients, elimination of the need for phlebotomy right away. Not having iron available for red blood cell growth eliminates that need for phlebotomy and effectively achieves the number one goal in management of PV patients. At the same time, patients improve the quality of life. So these two aspects, normalization of the hematocrit below 45 by virtue of eliminating phlebotomy and improvement in quality of life, are being evaluated in this particular phase 3 blinded randomized study for possible approval of hepcidin as a new therapy for polycythemia vera in patients that need too many phlebotomies. In polycythemia vera, the red blood cells that grow without control utilize iron basically as a food for their growth. And typically, the patients with PV become iron deficient over time, in large part due to phlebotomy. Phlebotomy would get rid of red blood cells from the body, and with that, iron would go away. However, there is more effective way of doing that, and that is mimicking hepcidin. Hepcidin is a master iron metabolism regulator in the body of a person, and having rusfertide as a mimetic for hepcidin, what we effectively do in a patient's body is store the iron in the liver or a spleen or a lining of the GI tract, rather than allowing it to be freely available for erythropoiesis. So this is mimicking, in a way, a natural goal of what the therapies should be doing, eliminating the red blood cell count by limiting the availability of iron, a substance that is essential for red blood cell growth. So it is not a cytoreductive agent. It redistributes the iron, and with that effectively provides a clinical benefit to polycythemia vera patients, and that is control of a hematocrit below 45%, which was proven to decrease the thrombotic risk and decrease the risk of dying from those thrombotic events. So understanding the biology of polycythemia vera led us to development of this particular agent, which provides in a great majority of patients such a significant clinical benefit.